Okay, so thanks for the introduction there, Dr. Gleave. I'm John Suderman. For those of you who don't know me, one of the PGY4 residents here at UBC Urology. I'll give my grand rounds today on the advancements, and I'm calling them controversies in penile cancer management today. So we'll get going. So I'll start with a quick overview of my presentation. We'll start with a brief introduction of penile cancer, including some of the details on epidemiology, histology, and diagnosis of the disease. After that, I've split my talk into three kind of overarching controversies in the management of the disease. These controversies include, number one, optimizing our surgical practices for local disease. Number two, improving our understanding of when known modalities of the treatment should be used in advanced disease. And then lastly, I'll discuss the controversies in applying novel therapies in the advanced disease state based on a tumor's microenvironment. So overall, penile cancer is a rare disease. Worldwide, penile cancer makes up less than 1% of all newly diagnosed cancers in men, with approximately 95% being penile squamous cell carcinoma. Incidence certainly varies across the world, with lower income countries in parts of Asia, South America, and Africa having a higher incidence of the disease compared to higher income countries like the US and those in Western Europe. In the US, there are approximately 2,000 new cases and less than 500 deaths from penile cancer each year. Penile cancer is typically diagnosed in older men with a median age at presentation of 68. However, up to 20% of patients may be under the age of 45 at first diagnosis. Here you can see a so-called heat map of the estimated incidence on the left, and then the mortality on the right in 2018 for penile cancer globally. Note the particularly endemic regions, including Africa, South America, and parts of Asia. So the disease prevalence has been shown to vary by race and ethnicity within the US. Hispanic men have the highest incidence, and Asian men have the lowest. Interestingly, white and black men have similar rates of the disease. However, there are significant survival differences between the two groups. Notably, African American patients have a 2.2-fold higher risk of death compared to white men with similar disease. I don't think it's unreasonable to speculate that this is largely due to both the ability to access healthcare and receive timely treatment for the two populations in America. In the figure on the right, Chi showed a downtrending penile cancer incidence until about 1987, relative stability for about a decade, and overall an increase thereafter. According to Chi, this trend may be explained by changes in sexual practices with a subsequent increased exposure to oncogenic HPV infections, along with a decline in childhood circumcision rates. Thankfully, despite the increase in diagnosis over that time, mortality rates have continued to fall, likely secondary to improving management strategies and access to healthcare. Of course, risk factors for developing penile cancer are well established. Risk factors include phimosis, lack of neonatal circumcision, obesity, HPV infection, tobacco use, recurrent balanitis, lichen sclerosis, and penile UVA exposure. In 2016, the WHO updated its classification system for penile cancer squamous cell carcinoma. The WHO stratifies disease histology as either HPV related or non-HPV related based on whether the subtype is usually related to HPV infection. Non-HPV related disease includes usual, pseudohyperplastic, pseudoglandular, verrucous, papillary, adenosquamous, sarcomatoid squamous, and mixed carcinoma. And HPV related SCCs include basaloid, papillary basaloid, warty, clear cell, and lymphoepithelioma-like carcinoma. Confusingly, not all HPV-related penile SCCs are histologically HPV positive, though HPV positivity is much more common in these variants. You can see the HPV-related variants include warty carcinoma with an HPV positivity rate ranging from 22 to 100%, which is, of course, a very wide range. Penile intraepithelial neoplasia, which are premalignant lesions, can be classified as either basaloid, warty, or differentiated. Basaloid and warty are considered HPV-related, while differentiated isn't. The AJCC uses a three-tiered grading system based on WHO and ISUP grading. Grade 1 represents well-differentiated disease, grade 2 is moderately differentiated, and grade 3 is poorly or undifferentiated. The presence of anaplastic cells automatically places the tumor as grade 3. The majority of verrucous, papillary, caniculatum, and pseudohyperplastic carcinomas are well-differentiated or grade 1, whereas sarcomatoid, basaloid, clear cell, lymphoepithelioma-like carcinomas are usually poorly differentiated or grade 3. So the diagnosis of penile cancer can often be obvious with an exophytic tumor. However, ulcerative lesions have a wider differential, including inflammatory disorders or STIs. Physical exam of the penis and lymph nodes is, of course, mandatory with good reliability in non-obese patients. Phimosis is present in 25 to 75% of patients, and these patients require a dorsal slit in order to properly examine or biopsy the lesion. In obese patients, imaging with penile MRI does improve staging of the primary lesion, specifically in identifying invasion into the corpus cavernosum. However, in disease that's less than or equal to T1B, MRI adds very little value and shouldn't be used. So this image is basically just meant to show the breadth and visual presentation for premalignant and malignant subtypes of penile squamous cell carcinoma, notably where visual inspection alone may be insufficient for diagnosis. So tissue is therefore obviously required to appropriately diagnose and stage the patient. Non-invasive superficial cancers can be misdiagnosed and incorrectly treated with multiple rounds of topical antifungals or steroids. Things we should expect in the pathology report include depth of invasion, pathological grade, presence of lymphovascular invasion, and perineural invasion, as this information is required to correctly stage the disease. Imaging in the form of CT abdo-pelvis is usually reserved for high-risk disease, which I'll discuss a little bit more in my talk later on. Those with nodes difficult to examine, node positive, or palpable lymphadenopathy. Of course, everyone is already aware of the T staging for penile cancer. We'll quickly review a couple of the changes in the 8th edition of the AJCC staging system, which has shown improvement in prognostic value over the 7th edition. The major changes include, number 1, incorporating the 3-tiered histological grading system from the WHO that I already mentioned. Number 2, including the presence of perineural invasion, as this was recognized as an important prognostic factor. And this now separates T1A from T1B tumors. Number 3, T2 disease now includes invasion of the corpus spongiosum. And lastly, T3 includes invasion into the corpus cavernosum. So all of this kind of brings me to controversy number 1, which is optimizing surgical management for local disease. I think as surgeons, we should ask ourselves how we can best cure patients with local disease without compromising a man's quality of life, sexual, and voiding function. Historically, radical penectomy was the de facto treatment for those with penile cancer. Of course, there has been a shift towards more conservative penile-sparing approaches for local treatment in patients with favorable primary tumors. The goals, of course, of penile surgery include maintaining voiding function, and that includes the ability to stand while voiding, and maintaining sexual function if possible. Interestingly, greater than 95% of malignant tumors of the penis originate from either the inner mucosal lining of the glands, the coronal margin, or the foreskin. Less than 2% of lesions originate from the penile shaft itself, which obviously awards surgeons an opportunity to preserve the penile shaft in many operative scenarios. From a quality of life perspective, penile cancer can be a devastating diagnosis, especially for a younger and sexually active man. Madineni assessed psychological well-being, quality of life, and sexual function in a meta-analysis on those with penile cancer. 128 patients from 6 studies were included in the analysis. The study showed impaired general well-being in up to 40% of patients. Clinical anxiety was found in up to 31%, while mental illness was found in up to 53% according to the DSM-3. 40% of patients were shown to have PTSD after partial or total penectomy. Between 36 and 78% of patients had no or reduced sexual function after intervention for penile cancer. Drager attempted a similar review in 2018, addressing psychosocial effects of penile cancer treatment on quality of life and sexual function. The paper posits that defects or mutilation due to penile cancer causes psychological distress, and organ-sparing intervention have a positive impact on quality of life and sexual function. In 2018, Simpson examined the SEER database in the US, where they found an incidence of 13 suicides in over 6,000 patients with squamous cell carcinoma of the penis. All patients who committed suicide were between the ages of 50 and 79 years of age. Penectomy was found to be a statistically significant risk factor for suicidality. Drawing conclusions from a population study for a rare diagnosis is obviously difficult, but it stands to reason the younger males that are sexually active are more likely to experience negative psychological symptoms after penile surgery. Novak studied the psychological effects of penile cancer in 13 patients treated in Romania. The image on the right shows scores for depression on the top and anxiety on the bottom, or worse for those undergoing total penectomy relative to those undergoing partial penectomy, and then also those undergoing circumcision. So generally, TIS or T1 lesions can be managed by either local excision or with local incision with negative surgical margins. A 9% recurrence rate was found in a study from the UK, including 179 patients managed with a circumcision or wide local excision with negative margin. Philippou found that the predictors of local recurrence were tumor grade and also presence of lymphovascular invasion. Among patients who did have a local recurrence, up to 76% may be successfully salvaged with further penile sparing techniques without detrimental impact on overall survival. The use of topical therapies should obviously be reserved for TIS lesions. Topical agents include 5-FU and 5% imiquimod. Recurrences were quite common even among initial responders. There are also significant local irritative symptoms, making compliance challenging at times. Close follow-up and repeat biopsy are certainly required for new or persistent lesions. Alternatively, laser ablation can be used in patients with TIS or T1A lesions. Laser ablation can be performed in the office under local anesthetic or in the operating room. Acetowhite testing can help detect occult HPV-positive lesions and is performed by applying acetic acid to the penile tissue. These lesions appear white and become easier to detect, as you can see in the image on the right there. Recurrence rates using laser ablation have been reported at 7% in TIS and have ranged from 10 to 25% in T1 lesions. Radiotherapy may be an option to treat local disease for patients not amenable to organ preservation or who are not surgical candidates. Options include EBRT or brachytherapy. Circumcision is required to prevent complications from edema or inflammation secondary to the radiotherapy. Small distal lesions less than 4 centimeters may be treated with either one of the modalities. Brachytherapy long-term control has been found to be as high as 87% with penile preservation up to 88% at 5 years. EBRT has shown inferior tumor control with penile preservation rates at 36 to 66% and cancer-specific survival between 56 and 86%. Usually high doses of radiation are required to eradicate penile SCC. As a result, acute and delayed complications, including skin erythema, urethral mucositis, edema, secondary infections, and eventually down the road, meatal stenosis or necrosis, are not uncommon. With regard to partial penectomy, a 2 centimeter gross surgical margin has historically been considered the gold standard, originally proposed by Spalding and Grabstall in 1979. Agrawal prospectively reviewed 64 partial and total penectomy specimens to determine the microscopic spread of tumor beyond the gross margin. They observed that 81% of tumors did not spread beyond the gross margin, and of those that did, 75% did not spread beyond 5 millimeters. SRI evaluated 330 patients with a clear surgical margin managed with a penile sparing surgery. 64% had a less than 5 millimeter margin. Not surprisingly, they found an increased risk of local recurrence in patients with a margin less than 1 millimeter versus greater than 1 millimeter. The NCCN and EAU guidelines recommend surgical margins ranging from 3 to 10 millimeters, depending on the stage of the disease, awarding more opportunity to spare penile length relative to historical benchmarks. Total penectomy and perineal urethrostomy remains the gold standard for patients presenting with bulky, invasive, or high-grade cancers at higher risk of recurrence and progression. The advantage of amputation is obviously the lower rate of recurrence. A meta-analysis showed that among 785 men undergoing any form of penile-sparing surgery versus amputation, the cumulative recurrence-free rate was 76% for penile sparing and 93% for amputation. For men who have undergone total penectomy, phallic reconstruction is now becoming an option. Radial forearm free flap reconstruction is the most common modality used. Penetrative intercourse is sometimes possible with the neophallus alone, though sometimes a penile prosthesis is required for improved rigidity. The image shows a general outline of phalloplasty using a radial free flap. In the left panel, a full thickness flap is raised on the radial artery with cutaneous nerves intact. The middle panel shows how the flap is formed in 2 parts to create the urethra and phallus. And the right panel shows how the neophallus is attached and positioned. Data on phalloplasty following penectomy for penile cancer is extremely sparse, given the rarity of the condition and complexity of reconstruction. Only one retrospective study has reported the outcomes of penile reconstruction following penile cancer, which only included results from 15 patients along with a handful of case reports. This study showed functional and cosmetic outcomes following phalloplasty were excellent after a median follow-up of 20 months. All men were satisfied with the cosmesis and size of the neophallus, and 87% of men reported sensation. 5 out of 6 men with a penile prosthesis could engage in sexual intercourse. Of course, the reconstruction options for phalloplasty are currently in their infancy, and speaking with Dr. Kavanaugh, who provides local expertise on the topic, phalloplasty is likely an underutilized approach for reconstruction in healthy candidates. In particular, phalloplasty without urethral reconstruction has a very low complication rate and is unlikely to make a major impact to disease surveillance after radical penectomy. So this brings me to controversy number 2 in my talk, which I've entitled Improving What We've Got. I'll show you that clinical outcomes significantly drop with worsening nodal and metastatic disease, but there's debate in this space on the appropriate order and modality of management, which requires optimization. So we're all aware of the lymphatic drainage from the penis. Lymph drains from the penis to the superficial inguinal lymph nodes, then to the deep, and then to the pelvic lymph nodes. Data has shown that the extent of nodal involvement is the most important predictor of death from disease. 3-year cancer-specific survival for pathologic N1 disease is 90%, but drops dramatically to 60% for N2 disease. Survival decreases further to 33% for those with N3 disease. Managing patients with non-palpable lymph nodes is generally straightforward, at least according to the NCCN guidelines. Low-risk disease, including those with TIS, TA, and T1A disease, is managed with primary lesion control and surveillance, given their low risk of developing metastases. Intermediate and high-risk patients should prompt lymph node dissection or sentinel lymph node biopsy. Importantly, small volume disease found at the time of prophylactic or staging inguinal lymph node dissection is generally thought to be curable. But if you delay inguinal node dissection until there's palpable disease, there becomes a lower likelihood of cure. Some groups, including the EAU, disagree with chest imaging in a patient with node-negative disease, especially in those with a T1B tumor. Chest imaging for palpable inguinal nodes is fine, but usually shouldn't be ordered for N0 cancer, regardless of T stage, and isn't ordered in that indication at our center. Though it is not unreasonable to order a staging CT for any T2 disease or higher. Disease spread to the chest is usually seen in the worst cases, and usually sometime after diagnosis of inguinal or pelvic disease. The usual scenario being that the patient would have an inguinal or pelvic lymph node dissection, ends up on some adjuvant therapy, and then a couple of years later develops lung metastases. With that said, the NCCN splits palpable inguinal lymphadenopathy into non-bulky and bulky disease. Non-bulky disease includes unilateral positive lymph nodes less than 4 centimeters. Bulky disease includes lymph nodes greater than 4 centimeters, fixed or bilaterally palpable lymph nodes. In the non-bulky disease pathway, there is pathway ambiguity with N2 or greater disease, in that pelvic lymph node dissection, chemoradiation, or chemotherapy are all acceptable options. With bulky lymphadenopathy, we run into similarly ambiguous recommendations for adjuvant therapy. If 2 nodes are found to be positive on inguinal node dissection, or in those who underwent neoadjuvant chemo with a positive clinical response. There's clearly lacking data in the space to differentiate the outcomes of chemotherapy, chemoradiotherapy, and radiotherapy in patients with node-positive disease. Despite a lack of randomized studies, expert consensus supports the use of neoadjuvant TIP chemo in patients with locally advanced or N2 or N3 disease. Azizi completed a meta-analysis with a total of 182 patients from 10 studies regarding neoadjuvant chemo for locally advanced penile squamous cell carcinoma. He found that neoadjuvant chemo achieved pathological complete response in 15% of patients and an objective response rate of 50% for N1 to N3 disease. Necci's multicenter retrospective study reported improved survival following adjuvant chemotherapy, particularly in patients with pelvic lymph node metastases. Despite neoadjuvant chemo, there is still a poor 5-year overall survival of less than 50% in patients with N-positive disease. Data on the use of primary radiotherapy and chemoradiotherapy in penile cancer are also scarce and is more or less borrowed from other cancer types. Primary radiotherapy is the modality of choice in other anogenital SCCs such as anal or vulvar cancers. This may suggest a role for radiotherapy on lymph node mets and penile SCC as well. In an RCT studying patients with vulvar cancer following inguinal node dissection, adjuvant radiotherapy to the inguinal and pelvic basins has shown improvement in overall survival. However, its role in penile SCC is certainly debated, and guidelines are conflicting at this time. The NCCN endorses radiotherapy as a definitive treatment, whereas the EAU only recommends radiotherapy for palliation. Gianna Tempo presented some preliminary findings at the GU ASCO in 2020 for a large retrospective study of perioperative nodal radiotherapy in locally advanced HPV-positive penile SCC. The study showed that HPV-positive cancer may be more radiosensitive than HPV-negative cancer. However, as the evidence stands, the optimal role for radiotherapy for lymph node mets at this time is uncertain. This leads me to the International Penile Advanced Cancer Trial, or IMPACT. This study out of MD Anderson aims to prospectively determine the benefits and sequencing of surgery, chemotherapy, and chemoradiotherapy for patients who have palpable or inguinal lymph node mets present on imaging. They aim to answer a few questions, including what is the role of neoadjuvant therapy, and does either chemotherapy or chemoradiation provide superior outcomes? Secondarily, among patients with prior inguinal lymphadenectomy and adverse features receiving chemoradiation, what is the role of prophylactic pelvic lymph node dissection? Unfortunately, this study has been slow to accrue thus far, and the results haven't been reported yet, but hopefully it'll help to clarify treatment in this disease space once they accrue and report. Finally, patients with relapsed or metastatic disease unfortunately have poor outcomes. Wang reported on a 30-patient cohort with non-metastatic N2 or N3 disease treated with neoadjuvant TIP prior to lymph node dissection. 19 patients had tumor progression or recurrence. Of the 19, 17 had one or more salvage therapies with median survival from first treatment failure of 5 months. 4 patients underwent salvage surgery, all of whom experienced further disease progression within 2 months. 4 patients received chemoradiotherapy, 1 with stable disease for 13 months, and 3 with no apparent benefit. Median overall survival was about 5.5 months for patients who had received a second cisplatin-based treatment at any time, and 4 months for those who had not. I think it's pretty clear that there exists an unmet need for effective systemic therapies in this space and in advanced penile cancer. This leads me into controversy number 3 regarding advanced disease and novel systemic therapeutics. We're going to explore their role in advanced penile cancer management. So overall there's been increased interest in defining the tumor microenvironment and immune landscape of penile cancer. Ghislaine did such a great job last week explaining the molecular pathways involved in immune checkpoint blockade for non-muscle invasive bladder cancer that I won't reinvent the wheel with my explanation this week. Basically, immune checkpoints regulate the immune system as not to attack its own cells in an indiscriminate manner. PD-1 and CTLA-4 provide negative immune feedback, which can suppress the body's T cell responses. The PD-1, PD-L1 axis is obviously important in tumor immune evasion, and we all know immune checkpoint blockade using anti-PD-1 and anti-PD-L1 therapies have become frontline treatments across multiple other cancer types. Despite the currently limited use of immunotherapy in penile cancer, studies have been conducted to characterize PD-L1 expression in the disease. In a cohort of 40 patients at an academic center in Brazil, Tobacco used immunohistochemistry staining to identify those with PD-L1 positivity in the primary tumor. His team found that 69% of patients with lymph node metastases demonstrated PD-L1 positivity in the primary tumor. In a retrospective North American series of 53 invasive penile SCCs, Cox demonstrated PD-L1 positivity in 40% of the primary tumor samples, 44% of pathologic stage T2 or greater, and 38% of node-positive disease. Currently, the NCCN only recommends pembrolizumab as second-line treatment for patients with relapsed or metastatic disease that is unresectable, has high microsatellite instability, or is mismatch repair deficient. This recommendation is largely based on Maribel's report on the phase 2 Keynote 158 trial. This looked at the efficacy of pembrolizumab in patients with advanced non-colorectal, high microsatellite instability, or mismatch repair deficient cancers. Solid tumors included endometrial, gastric, cholangiocarcinoma, pancreatic, among others. However, no penile SCCs were included in the study. The primary endpoint was objective response, with an overall objective response rate of 34%. In the US, any locally advanced or metastatic solid cancer with high tumor mutational burden or mismatch repair deficiency is eligible for pembrolizumab after failing first-line therapy. MMR deficiency in penile cancer is pretty rare, but high tumor mutational burden is likely more common, which I'll talk about in the next slide. Unfortunately, we do not have the same approvals in Canada compared to those in the US, and we therefore don't routinely screen for either mismatch repair deficiency or tumor mutational burden on a local basis. Regarding tumor mutational burden, Chahoud completed a whole exome sequencing analysis on 34 primary penile SCC samples and showed that tumor mutational burden of penile cancer is comparable to cervical, esophageal, and head and neck squamous cell carcinomas. In general, a higher tumor mutational burden is associated with an improved response to immune-based therapies. Mutational signatures also showed significant molecular similarities between penile, head, neck, and esophageal squamous cell carcinomas. Although we consider immunotherapy for SCC in other organ sites, including the lung, anus, esophagus, head, and neck, there's no reason to think SCCs in the penis would be any different at this point in time. This brings me to cemiplimab, which is a highly potent human monoclonal antibody directed against PD-1. This drug has been studied in the context of advanced cutaneous squamous cell carcinoma. Migden reported on a phase 2 study in patients with metastatic disease, where the primary endpoint was the response rate to therapy. Overall, they found a response, whether complete or partial, in 28 of 59 patients for 47%. Among the 28 patients who had a response, the duration of response exceeded 6 months in 57%, and 82% continued to have a response at the time of data cutoff. 15% had an adverse event, and 7% discontinued the treatment because of one. The image shows the time to response and the duration of response for the 28 patients in the metastatic disease cohort. Gross conducted a phase 2 confirmatory multi-center non-randomized study to evaluate cemiplimab as neoadjuvant therapy in patients with non-metastatic and resectable cutaneous squamous cell carcinoma. Patients received cemiplimab 350 milligrams every 3 weeks for up to 4 doses before undergoing surgery with curative intent. The primary endpoint was a pathological complete response, which was observed in 40 patients, and a pathological major response in 10. An objective response on imaging was observed in 54 patients, or 68% of the cohort. Grade 3 or higher adverse events was only seen in 18% of the patients. Based on these grounds, cemiplimab was approved by Health Canada and is being used in Ontario for penile SCC. However, BC is slow to support the drug, so it's not accessible locally at this time. Use of atezolizumab, an anti-PD-L1 immunotherapeutic, has recently been assessed in the setting of patients with advanced penile cancer with or without radiotherapy. DeVries assessed the activity of atezolizumab in a single-center, non-randomized phase 2 trial of 32 patients with advanced penile cancer. The primary endpoint was 1-year progression-free survival. Unfortunately, 1-year PFS was only 12.5% in the study, which did not meet the primary endpoint of 35%. However, they did find that improved PFS was observed in patients with high-risk HPV-positive tumors, along with those who had high infiltration of intratumoral CD3, CD8-positive T cells, suggesting high immune activity. The study suggests that some biomarkers such as high-risk HPV and intratumoral CD3, CD8 T cell infiltration may help to better select responders, and further studies may be warranted in this realm. Changing gears a bit from immunotherapy, I've alluded to the fact that HPV infections can be oncogenic in nature. Essentially, HPV causes carcinogenesis by integrating itself into a host chromosome. The genome is divided into early or E regions and late or L regions. When the HPV genome is integrated, E6 and E7 gene expression is maintained, but other regions are lost. Loss of the E2 region is significant, as this represses transcription and can lead to unregulated E6 and E7 expression. Studies in cervical cancer have confirmed this pathway, as some studies showing re-expression of E2 in cervical cancer cell lines causes growth suppression. Specifically, the E7 oncoprotein disrupts the cell cycle by binding to and inactivating the human retinoblastoma protein. The E6 oncoprotein induces p53 degradation, which usually induces cell apoptosis. Both pathways induce neoplasia. Notably, this downregulation of apoptotic signaling leads to an accumulation of the tumor suppressor CDKN2A, which can be used as a surrogate immunohistochemical marker for an active HPV infection. On the flip side, HPV-unrelated penile cancers have been shown to harbor p53 mutations with little CDKN2A expression. Of course, HPV infection has been linked to oropharyngeal, vulvar, anal, cervical, and penile cancer. Common oncogenic HPV subtypes include 16, 18, 31, 33, with HPV 16 being the most common, as you can see in the figure. In a meta-analysis involving 4,200 patients with penile cancer, the results showed that 50% of the total cohort was HPV positive. 72% of HPV-related tumors were HPV positive, whereas only 19% of HPV-unrelated tumors were HPV positive. Notably, 80% of patients with penile intraepithelial neoplasia were HPV positive. Recent studies explore the tumor microenvironment in HPV positive and negative tumors. Ottenhoff found that the incidence of PD-L1 positivity was higher in HPV negative compared to HPV positive tumors. Diffuse PD-L1 expression and lymph node metastases were predictive of worse disease-specific survival for patients negative for HPV. Additionally, patients negative for HPV had worse disease-specific survival than patients with high-risk HPV-positive disease. The author suggests that there may be some degree, maybe a greater degree of immunosuppression in HPV-negative tumors, which may be contributing to worse overall survival. Therapeutic HPV vaccines are in development for other HPV-related tumor groups. Vaccines can stimulate the immune system and enhance cytotoxic T-cell response to HPV-positive tumors. They may also promote the development of immune memory against HPV-positive tumor cells. An example is Ankara, which is a viral vector expressing E2. In Rosala's study, Ankara was used to treat intraepithelial lesions in 1,100 women with cervical intraepithelial neoplasia or condyloma lesions, and 180 men with urethral condyloma lesions or anal lesions. Complete elimination of the lesions was observed in almost 90% of women and 100% of men. Unfortunately, in the context of penile cancer, no human studies investigating therapeutic vaccines have yet been published. Regarding prophylactic vaccination, HPV is thought to cause about 95% of anal cancers, 75% of oropharyngeal cancers, 75% of vaginal cancers, and 70% of vulvar cancers. In the US, the incidence of oropharyngeal cancer in men is now higher than cervical cancer in women. In Canada, HPV vaccination is recommended in males aged 9 to 26 and older if at risk for ongoing HPV exposure. Rates of HPV infection have dropped since the implementation of vaccination programs for young females. In 2016, the U.S. Centers for Disease Control and Prevention reported a study comparing HPV infections before 2003 and after 2012. The prevalence of HPV types 6, 11, 16, and 18 decreased by 64% in sexually active females aged 14 to 19, and by 34% in females 20 to 24 years old. In my opinion, efforts should be made to continue to prophylactically vaccinate males as well as females, as this may have the potential to eradicate or at least significantly reduce HPV-related cancers. So in conclusion, opportunities exist to improve functional surgical outcomes without compromising oncologic outcomes. Advanced disease paradigms require further investigation to elucidate appropriate treatment pathways. And lastly, novel systemic therapeutics can likely be applied in the setting of advanced penile cancer. Special thank you to Dr. Kavanaugh and Dr. Black, who both helped review the slides for this presentation. And with that, I will open things up to questions.